to discuss relevant issues of diagnosis of non-alcoholic fatty liver disease. What is non-alcoholic fatty liver disease? So it is a disease which is characterized excessive accumulated fat in the liver, which is associated with insulin resistance, and it is guided by the fact that we see steatosis more than in 5% of total amount of hepatocytes as a result of histology, or there is increased density of fatty fraction according to proton magnet resonance spectrometry. Non-alcoholic fatty liver disease includes two morphological forms with a very different prognosis. This is non-alcoholic fatty hepatosis, so simple fatty dystrophy, and non-alcoholic steatohepatitis, NASH, where there is some active cytolysis activity. That means non-alcoholic fatty liver disease could be associated with fibrosis, and in some cases it could progress up to cirrhosis and hepatocellular carcinoma, HCC. So both fibrosis, cirrhosis, and HCC could be considered as quite natural, evolutional, consecutive stages of natural course of one disease. The descriptions started long ago, already more than 250 years, starting from 1884. At that time, von Faley, for the first time, described the changes of the liver in diabetes type 2 up to 2000, where we, for the first time, enjoyed this term, non-alcoholic fatty liver disease, NAFLD. Pathogenesis is normally described by two approaches, a theory of two hits, which describes the development of non-alcoholic fatty liver disease, and then later on in 2010, and Motion offered the theory of multiple hits. Well, to me, as a clinician, to me as a specialist currently, both theories are not answering main question, when and why somehow for the first time hepatocytes start accumulating triglycerides, and it's becoming a very important pathogenetic chain in the pathogenesis and future development of metabolic syndrome and diabetes as well, diabetes type 2. So the theory of multiple shots, many factors, microbiome of the gut, and toxicity, all that is supporting pathogenetic importance of non-alcoholic fatty liver disease. But the topic of my presentation today is the diagnostics. The main risk factors for the development of non-alcoholic fatty liver disease, we refer metabolic syndrome, then nutritional behavior, hypodynamia, sedentary lifestyle, ethnic origin, and also other risk factors. Speaking about the prevalence of non-alcoholic fatty liver disease, we have to say that according to the data of statistical follow-up, the prevalence of this disease in the Russian Federation is about 37%. 37%, possibly it's a bit higher, or maybe it should be a bit lower, but in fact, it actually meets our nutritional preferences and our lifestyle. Progression of non-alcoholic fatty liver disease, and we spoke already about its evolutional stages up to cirrhosis, steatohepatitis, and hepatocellular carcinoma. Definitely, it is associated with particular known, well-known from the point of evidence-based medicine statistics. This is age 50 plus. Then genetic predisposition, genetic specificity. I do apologize for my coughing. Then abdominal type of obesity. And presence of diabetes type 2. Type 2 diabetes and non-alcoholic fatty liver disease, NAFLD, are going hand in hand. Two very important factors that influence each other. Specifically, I would like to talk about the polymorphism of a gene, PNLPA3. This is gene of peptidin kinase, where it has been shown that if there is GGLL, we see 73% higher lipids in the liver and higher risk of cytolysis of hepatocytes, higher risk of liver cirrhosis, and higher risk of HCC, hepatocellular carcinoma. And as a result of that, many communities today, when they detect genetic polymorphism of PNLP3, it's important prognostic criteria and for the course of the disease. If we speak about the combination of non-alcoholic fatty liver disease in patients with type 2 diabetes, we have to mention that the leading medical communities like European Association on Studies of the Liver, Asian Pacific Association to Study Liver, and British National Healthcare Institute says that these are very important diagnostic tests for diabetic patients. We have to say, when we characterize the natural cause of NAFLD or response to the treatment which could be provided currently, we have to say that to us, a very important thing is to identify steatotic rate and also fibrotic rate as markers of particular clinical stage that maybe is seen for the first time when patients is diagnosed. Speaking about the steatosis diagnosis, we have to say about non-invasive calculators and such methods like CT, abdominal CT, then MRI, ultrasound abdominal study, and we will have separate presentation on that today. And another parameter, specifically measurement of slowing down. Here you can appreciate different non-invasive tests. Steata test with sensitivity of 90% of specificity 88, then fatty liver index, which is also important, and also liver fat score in NAFLD with a lower specificity. Ultrasound of the abdomen, this is very important. We have to say that this is commonly available and it has some advantages. So this is rather cheap, also short time of study, no radiological burden, and definitely it's non-invasive and painless. But there are minuses for the ultrasound. With the help of ultrasound, you cannot identify the stage of NAFLD. A lot depends also on the qualification of the doctor and BMI of the patient. CT also identifies nicely all the features of non-alcoholic fatty liver disease, specifically steatosis, as a reduction of density, rentgenological density, and comparison of the density of liver spleen. So it should be 10 Hounsfield units lower. This method also has some pluses and minuses. Advantages according to its method. This is very standardized method. And it could be measurement of density of the organ. And also it has lower limitations than ultrasound. MRI diagnosis. There are several methods, Diggs method, PDFL mapping, and also proton magnet resonance spectroscopy. Dixon method shown here. So B and E shows the steatosis mild, B and G moderate steatosis, and severe steatosis. The advantages of this method is pretty high specificity to identify triglycerides, TG. So this method could identify it, and in MRI, no ionization. Low reproducibility, and also fat could be influenced by the iron deposits and severity of fibrosis. And in this method, microvesicular, this method is not used in patients with cardiostimulators or implanted cardioverter defibrillators. This is another method. This is the percentage of triglycerides versus water. And this is common standard for the diagnosis of liver steatosis, at least in Russian centers. This method is actively used, PDFF mapping. So this is through impulse consequence on 3 Tesla machines. So this is healthy liver, then borderline steatosis and severe steatosis. It's a spectrum of several peaks. On the sensitivity, specificity, it's almost compared to biopsy. And this is the rate of steatosis in parenchyma. This is 98 and 96 correspondingly. The advantage of method is high diagnostic accuracy, high reproducibility of results with minimal deviations, but the minus of that probably yet we cannot do it through the standard scanners, and pretty high price and quite limited piece of liver parenchyma that could be analyzed. Another parameter, this is another parameter which is also used. It is called ultrasonic extinction or ultrasonic attenuation. So this is elastography. This is quite informative and also important method for the NAFL diagnosis and NASH as well. We spoke about liver fibrosis as a stage of evolution development. But also there are non-invasive scales to assess fibrosis of the liver, ultrasound elastography, also MRI elastography, and also biopsy of the liver. This is an important component of the diagnosis to identify the stage of the disease. Non-invasive scales for fibrosis assessment are very important. So this is very important, so-called NAFL, the fibros score, NFS, then fibrosis score calculator, FIB4, FIB4, also enhanced liver fibrosis, ELF score, and they use other parameters, hyaluronic acid and terminal procalugan 3 and other parameters, and fibro test, which is most frequently probably used and performed in the institutions where, in fact, they are dealing with them practically. Ultrasound elastography of the liver. It has 2 types of examination, so transient elastography and elastography of the shift wave shift. So transient elastography, this is non-invasive. This is identification of rigidity of tissue. So we know this is as fibroscan, so I'm not going into the depth of that because my task today is to speak generally. My task is to be concentrated on the main positions of diagnosis. So this method is very well known, transient elastography. Elastography of the shift wave. This is very new, non-invasive way of ultrasound elastography, and specificity of this method. You can identify, you can reliably select the particular piece, shear wave elastography, transient and shear wave elastography. So there are some limitations in both ascites, obesity, acute hepatitis, chronic hepatitis with increased transaminases, also extra hepatic cholestasis, chronic heart failure with edemas into biventricular or left or right ventricle, and also very narrow interrib intervals. MRI elastography, that's non-invasive method, which is based on MRI for the measurement of the rigidity of the liver, to use modified method of so-called phase-based contrast. Sensitivity and specificity of this method is 84 and 90% correspondingly. Here at the top, you can see a wave of for patients with fibrosis confirmed by biopsy. So this is stage 1 to stage 4. And in the lower rate here, you see corresponding elastograms. So this is example of MR elastogram. This is steatohepatitis, which is complicated with ascites. So that's very good visualization. Elastogram B. To my position as hepatologist, as a practitioner, liver biopsy is a golden standard for the diagnosis of non-alcoholic fatty liver disease and mainly steatohepatitis and fibrosis rates, although there are some limitations here. And then biopsy is well indicated in particular cases from the formulation of clinical indications when the competitive etiology of chronic disease of the liver cannot be excluded only with lab studies or personal anamnesis or other methods that I just spoke about. Or in case of a little bit faster progression of the disease. So these are classical 4 stages of progression, progressive disease that is called non-alcoholic steatohepatitis. So simple fatty dystrophy to morphological clear cirrhosis with the false lobes. Thank you very much for your attention. And now it's my pleasure to give the floor to our next speaker, and this is Ella Piñaeva, with really very interesting presentation, the role of ultrasound diagnosis or ultrasound studies in the diagnosis of non-alcoholic fatty liver disease. And I would like to ask speakers to stick to the timing, and thank you very much for the understanding. Good afternoon, dear colleagues, dear friends. First of all, let me thank the organizers for the opportunity to speak up today on behalf of ultrasound community. So it would be easier for me to do it because Igor already covered partly what I was planning to talk about. Let us start. So today, we will discuss this topic according to the relevant clinical guidelines, which you see here on the screen. So these guidelines mainly dated 2023. So that means here you can hope that the most relevant information would be presented here. And also very novel methods of ultrasound diagnosis also reflected here. I'm not going into the depth of the fatty liver disease because NAFLD was already described, but let me mention that morphologically, non-alcoholic fatty liver disease is presented here by steatosis, inflammation, fibrosis, cirrhosis, and possible HCC. And the methods of diagnostic visualization normally based on the identification of morphological changes, as well as we don't see the function. What we can see is a change of the structure only. Before the development of cirrhosis, they believe that pathological changes in the liver are potentially reversible. And that is why the most important task of these methods of medical visualization, to identify steatosis, fibrosis at the stage where potentially we can see the regression of these changes. Because when we see the patient with cirrhosis, we have to say that probably it's too late to diagnose, and our role here is just screening of complications, and that's it. So what can we offer? What can we offer to our doctors, clinicians from the position of ultrasound diagnosis? Well, first of all, ultrasound study, this is a first-line treatment to assess in the patient's visual assessment of the patients if we suspect any liver pathology. This method has very high diagnostic precision in the diagnosis, which is presented by ultrasound features like diffuse increase parenchyma, not clear vascular pattern, and distal attenuation of the signal. You see these pictures and the difference is very clear. So you see steatosis here. Also, according to the modern guidelines, they believe that steatosis is quite enough to make the diagnosis of non-alcoholic fatty liver disease without changes of the lab tests, even if you exclude other etiology for development of steatosis. It is proved that diagnostic precision is increasing while steatosis is increasing. Unfortunately, in the Russian Federation, it is not so prevalent, but in the world community, it is traditionally split steatosis according to the results of ultrasound into 3 stages: moderate, severe, that are correlated with histology of steatosis. Identification of steatosis is important not only for the rate of steatosis or severity of steatosis. It is important not only for the assessment of dynamics of progression or regression of steatosis, but also it's important for the prognosis of fibrosis. So in the studies of 2018, the authors using proton fat fraction proved that in patients with high level of fat, the progression of fibrosis happens very frequently, and the chance here is 7 to 1. And this is significant difference. Patients with steatosis, according to the ultrasound, quite subjective. It depends not only on the experience of doctor ultrasound, and also the light could be important. That's why manufacturers are trying to help us, and they design these automatized techniques that allow to characterize quantitatively steatosis using parenchyma as a reference zone. So this method is called hepatorenal index. This method it's increased reproducibility and reduced subjectivity. It has high diagnostic precision. And if you see steatosis more than 5%, as Igor already said, in ultrasound diagnosis, traditionally, when you do the visual assessment, it's very difficult to identify steatosis with accumulation of fat less than 20%. So this method increases the precision of diagnosis, although the use of it is limited in the patients after nephrectomy, and also in the presence of the kidney disease, which is associated with the changes of parenchyma. And also one of the most important tasks here of ultrasound diagnosis is identification of cirrhosis and portal hypertension syndrome and their complications. This is a standard. So invasive procedure is never cancelled for the diagnosis of portal hypertension, but Doppler study of the vessels give us quite complete information about the severity of portal hypertension here. So our task is to identify fibrosis, severe fibrosis and cirrhosis, and these pathologies, they have typical ultrasound features, for example, not clear contour, non-homogeneity of the structure, hyperplasia of the tail, and also features of portal hypertension, although it's high specificity, but not enough specificity. So when you look at the ultrasound study, we can predict that in these patients with high probability, we have liver cirrhosis. But we cannot exclude cirrhosis here. So that's the biggest problem, especially in the patients with non-alcoholic fatty liver disease, because steatosis of the liver is actually removes this non-homogeneity of parenchyma structure that we see in patients without fatty infiltrations, and we can suspect it fibrosis and actually refer patients for the additional examination. Also, ultrasound study is not sensitive for intermediate stages of fibrosis, fibrosis F2, F3 by Metaver scale, which you can see on the case. With the same ultrasound picture, in these patients, we have very different stages of fibrosis. And here on the left, we can see that stiffness and elastometry was already mentioned. So here, stiffness mid-stage 2-3, but with the same ultrasound picture, on the picture on the right, we can see that patient has no fibrosis at all, no fibrosis at all. Significant fibrosis is very important because in that case, we should start ultrasound screening of HCC and to do it once in 6 months. And what could be offered by modern recommendations? Non-invasive tests include serum markers and also rigidity of the liver. We can do different types of elastography. We identify 2 big groups, transient elastometry, which is very well known to doctors, hepatologists, because many of you already are aware about it and you use it in your practice, and also ultrasound elastometry, transient and ultrasound, both are shear wave elastography. But in transient elastometry, VCTE, generation of wave is down due to the mechanical effect to the skin, but in the ultrasound elastometry, the generation of shear wave happens in parenchyma due to the focused impulse. And then it allows us to measure the stiffness of the liver also in patients with ascites. And also visual control is important, and you can select the depth, which also allows us to increase the precision of the diagnosis. And at the same time, the methods of ultrasound elastography could be split into the pinpoint elastometry and 2D elastography. In these guidelines, we can perform elastography as an alternative to the transient elastography. It is reported there, but although not in all the guidelines, we mention the threshold levels that can potentially be used, and this is a big challenge of ultrasound elastography. Here you see the results of meta-analysis that included 82 studies and more than 14,000 patients with non-alcoholic fatty liver disease. When we identify separate stages of the fibrosis, we see big differences in the thresholds. First of all, it is related to the fact that different manufacturers of ultrasound technique offer very different threshold levels for the staging of the fibrosis. And this is influence of steatosis to the liver rigidity. And this is data of one author. And this is attenuation of the impulse. This is possible inflammatory activity. And this is American Association of Gastroenterologists offers the following algorithm of stratification of risk in patients after the identification of the risk group. The first step here, invasive diagnosis using serum markers, and then intermediate group elastometry of the liver. And we split patients into the risk level. Low risk are the patients with stiffness less than 8 kilopascal, and for them it's dynamic follow-up every 2-3 years. Well, stiffness from 8 to 12 kilopascals, it's intermediate group. And we can use other methods of diagnosis and also possibly biopsy. And also stiffness more than 12 kilopascals, these are patients of high risk group. And this is how we have totally different approach here, but you know it better than me. That is why we are not going to be focused on that. And separately, I would like to mention that these data were offered for transient elastography, but the authors of the guidelines, they mention that in these algorithms, they also can use methods of 2D elastography. American Association to study liver diseases, this threshold for 2D elastography absolutely meet the requirements. And also, I would like to mention that in 2015, in the consensus Bavena 6, so this is decompensating chronic progressive liver diseases in patients with liver hepatitis and non-alcoholic fatty liver disease. This is continuity, and this is the absence of clinical differences in the course of the disease, and also the risk of complications development in these patients. And the investigators identified thresholds which were formulated as a rule of five. So liver stiffness less than kilopascal is normal. Then more than 10 kilopascal, this is a rule out of a CLD, CLD from 10 to 15 kilopascal. So that was suspicious for CACLD, and additional methods are needed. More than 15 kilopascals we have to rule in. And finally, if the stiffness is more than 20 kilopascal, this is a rule out for clinically significant portal hypertension. And by Vienna 7 consensus 2022, all these thresholds were increased by 5 kilopascal, and today they are 10, 15, 20, and 25 kilopascal correspondingly. Then these thresholds were adapted for the ultrasound elastography, and They present it as modulo Young and also shear wave, because stiffness could be measured both in the shear wave and then recalculated into the Young module. Also, liver stiffness could be used not only for fibrosis identification and the stage of fibrosis, but also complication, portal hypertension. Let me say a few words. If it's less than 10 kilopascal, this is low, 3-year risk of decompensation and mortality. And if it's more than 20-25 kilopascal, keeping in mind the number of platelets, we can predict the presence of complications. So we're not going into the depth of that. All that is available in the clinical guidelines. And steatometry of the liver. So this is controlled parameters. Ultrasound is not behind. This is transient elastography. This method is actively introduced into the ultrasound scanner. So we increase the fat in hepatocytes. So ultrasound signal is absorbed better. So it can be properly registered by ultrasound scanner. And these are threshold levels. And this is how we can identify different stages of steatosis. This method includes clinical guidelines as possible method to assess steatosis. And also we mention here that diagnostic precision here and also threshold levels yet require particular clarifications. And another important method, innovative method, this is dispersion of the shear wave, which is used to assess the inflammatory activity. Igor already showed this chart with the factors confounders of inflammation and cytolysis. This is a pain of doctors who are doing elastography of the liver, because with inflammation, the rigidity of the liver is also increased. So assessing dispersion of the shear wave, we can facilitate to differentiate fibrosis and inflammation in patients with the increased rigidity of the liver by the result of elastography. And now a few words about the ultrasound study with contrast. So this is a method which is mainly used for the differential diagnosis of the liver tumors, but in patients with NASH, NAFLD, it could be used for non-malignant confirmation, because very frequently we see some sporadic steatosis or non-accumulation of the fat tissue with diffuse changes, and sometimes we need differential diagnosis. So with homogeneous contrast in parenchyma, so in all vascular phases, we can say that these pieces are non-tumor based. At the end, I would like to say that modern multiparametric ultrasound diagnosis is very useful for the assessment of pathological changes in the liver, and some of them are actively used in the clinical practice, and the rest are still proving their efficacy. But nevertheless, the clear diagnosis is a must. It is done only in the multidisciplinary cooperation, ultrasound specialists and clinicians, because before we refer to the diagnostic study, definitely we need to assess comorbidities and clinical and laboratory data of the patient. Thank you very much for your attention. And here you can appreciate QR codes, so you can see the text of the guidelines and contact me if needed. Thank you very much. Thank you very much, Leila. Thank you very much. I think brilliant presentation, and we know that Dr. Piñaeva is a very famous ultrasound specialist, and she has lots of patients. So colleagues, I think we maybe have discussion at the end of symposia if we have time, because we are a little bit behind the schedule. And now it's my greatest pleasure to introduce our distinguished guest from Greece, Professor Sarantis Livadas. He will speak about the impact of non-alcoholic fatty liver disease on prognosis. Please share your screen and the microphone is yours. Please start.
Thank you very much for your kind invitation. And the problem, as you hear from the previous speakers, is that this is a very common disorder which may develop to NASH and liver cirrhosis and liver cancer, so we have to take care about it. The global burden of both non-alcoholic fatty liver NASH is very wide. As it was shown before, in Russia it was higher than 10%. But there are several countries that have even more than 30%. So we have something dangerous and very common we have to deal with. What happened about insulin resistance? Because this is the main pathophysiological event in non-alcoholic fatty liver disease. We have a less net muscle glucose synthesis, which is very high in those with insulin resistance. We have a very high hepatic triglyceride synthesis, and we have furthermore de novo triglycerides. All this leads to increased liver adipose tissue in the liver, which is the main pathological finding in this disorder. Why is going that? Because insulin resistance increases not only glucose, but increases also amino acids and free fatty acids, which give birth to ceramides, which are very deleterious for the liver. And this is what happens through insulin resistance. Another big player in the pathophysiology of the disorder is the adipose tissue. We have lipotoxicity, which drives insulin resistance, and we have also the secretion of pro-inflammatory cytokines. Non-alcoholic fatty liver disease will be considered as a disorder with increased inflammation and increased insulin resistance. And the very interesting thing is that only 50% of liver is accumulated due to diet. The other fatty acids are de novo or reesterification of circulating free fatty acids, which means that it's an inherent metabolic disorder and not only a diet disorder, as it was thought. Why is that? Because we have a problem in the muscle, we have insulin resistance in the muscle, and we have also insulin resistance in the adipose tissue. All these lead to augmentation of liver in the fat, in the liver, and also fructose intake leads also to this disorder through Western diet. But if a disorder of muscle and what the adipose tissue insulin resistance becomes, then it's very difficult to overcome this problem. And this lipotoxicity and glucosopicity will lead to beta cell dysfunction. And this is important, yes, because as we know, except insulin resistance, we have also to have beta cell dysfunction to have dysglycemia and diabetes. And in the course of non-alcoholic fatty liver disease, we see that when these patients, they gain weight, they become obese, then insulin resistance goes up, insulin clearance goes down, and then we have beta cell dysfunction and the development of type 2 diabetes. So the connection of type 2 diabetes and fatty liver disease is very common. However, we should keep in mind that there are some people that have liver fat but a difficult degree of insulin resistance. That means there are other components, such as genetic components, such as what's mentioned before, that accumulate to fatty liver. So we should consider in our days non-alcoholic fatty liver disease as a manifestation of the metabolic syndrome, because all parts of obesity, dyslipidemia, hypertension, and diabetes contribute to the development of this disorder. On the other hand, we have to know the bidirectional way of NASH to diabetes and from diabetes to NASH. Non-alcoholic fatty liver disease is associated with a very high increased risk of developing type 2 diabetes. And on the other hand, the patients with diabetes have a higher prevalence of steatohepatitis. And of course, both they are insulin resistant in every aspect of glucose metabolism, muscle, liver, and adipose tissue. And this dysfunctional adipose tissue will increase the ectopic fat accumulation and the lipotoxicity, and glucotoxicity and lipotoxicity are associated with impaired insulin secretion, a prerequisite for type 2 diabetes development. And there is a big problem that has occurred the last years, how we should term this disorder. Should we keep the non-alcoholic fatty liver disease? Because it's used in sometimes medicine to describe a minor condition, but it's not a minor condition, it's 20 to 35%. That's why they proposed the new nomenclature as metabolic associated fatty liver disease, where we need hepatic steatosis with overweight, obesity, type 2 diabetes, or other metabolic risk abnormalities. There are pros and cons for everything, but this highlights the importance of metabolic fatty liver disease as a metabolic disorder. And why this is very important? Because as you can see, metabolic fatty liver disease is associated with disorder in a very high risk of type 2 diabetes and mortality, whereas non-fatty liver disease doesn't show us this big problem. Actually, this is a case study, 23 years follow-up, and you can see that cardiovascular mortality is higher in subjects termed with metabolic alcoholic fatty liver disease. Why is that? Because then inflammation leads to fibrogenic response in hepatic stellate cells, and this will produce to NASH and cirrhosis. This is what happened. We have an inflammation in the liver. And this is the impact of non-alcoholic fatty liver disease. We have obesity, we have type 2 diabetes, we have cardiovascular disorders, and some other aspects we should talk about. This is a very interesting study showing after a follow-up of about 15 to 20 years that the death is higher in subjects, children and young adults with this disorder. And why is that? Because we have a higher rate of cancer, higher rate of liver disease, and a higher rate of cardiometabolic disease. Indeed, we have arterial stiffness in this disorder. We have coronary artery calcification in this disorder, and the higher the fibrosis, the higher the calcification. And this leads to increased incidence of CVD, non-fatal CVD, or fatal CVD in these patients, which is of course higher in those with cirrhosis from those without cirrhosis. So we have a disorder that increases mortality. Why is that? Because it's the inflammation that goes to the cardiovascular system. There is a big correlation between CRP and IL-6, the main inflammatory proteins, in non-alcoholic fatty liver disorder. And these proteins will go to the vessels and they increase the prothrombotic state, which is and the filial dysfunction, which will lead to coronary arteries, stents, heart valves, and we have cardiovascular events. So you can see that genetic factors, gut microbiota, ectopic adiposity, in the inflammation of the liver will lead the cardiovascular incidence. Another very important and very useful hormone is androgens. We know that men with higher androgens have higher ALT levels, the higher risk of non-alcoholic liver disease. And we have seen that in male to female to male transsexuals, this leads to elevate the ALT levels and fibrosis. And of course, androgens are associated with hepatocellular carcinoma. A very common disorder with elevated androgens are PCOS. PCOS have high hyperandrogenemia, which is associated with insulin adiposity, and this will lead to non-alcoholic fatty liver disease, which is considered a major metabolic disorder in women suffering from the syndrome. On the other hand, estrogens have some protective effect, and you see that premenopausal, the prevalence of non-alcoholic fatty liver disease is significantly lower than in women post-menopause. So we think that estrogens offer a survival effect in women with non-alcoholic fatty liver disease, but post-menopause, these women should be taken care because they have a higher risk to develop non-alcoholic fatty liver disease in the future. Finally, we should keep in mind that the burden of this disorder, it's not only health-related, meaning the comorbidities of type 2 diabetes and obesity, but it has also mental health and the negative impact of physical health. Why that? Because we have a deterioration of quality of life, and many people don't feel well. And what means we don't feel well? This is the quality of life. And as you can see, this is the green line, which is the normal. All subjects with this disorder have a mean quality of index. This is the higher the non-alcoholic fatty liver disease, the lower the quality of life. So we have to know that our patients have a lower quality of life, and they also complain about fatigue. They don't feel well, and they complain about a pain in the liver. Finally, as everybody knows now nowadays, sleep is very important for general health. And all these subjects have a worse quality of sleep, duration, latency, chronotype, and quality, which totally impairs their quality of life, and we should keep that in mind. Finally, we should keep in mind that the impact of this disorder is not only on health or on quality of life, but it's also economic. It has been found that the direct medical cost are almost 3,000 euros, and the direct medical costs are 5,000 euros for a subject. And the direct cost for this disorder in the United States have been estimated of $100 billion. So we can imagine that we have to take care of this patient in order not only to improve their mortality and morbidity, but also for economic reasons. Finally, we should think that non-alcoholic fatty liver disease constitutes a metabolic disorder. It's not just a disorder of the liver. Insulin resistance is the main key player in the pathophysiology. And the impact of this disorder is tremendous because it affects drastically not only the survival, but also the development of other comorbidities, the quality of life, and health expenditure. Finally, I think that we need a better name for this disorder. Thank you very much.
Thank you very much, Sarantis. Fantastic, fantastic presentation. You see so many changes since our first and very early understandings about this disease. Famous Giannis epidemiological study, you remember that, carried out in Europe, then T-RECT, also large-scale study carried out in Russia. And now we understand that, wow, that's a new universe. And this is a very big multidisciplinary problem that requires not only active involvement of endocrinologists, gastroenterologists, but also psychiatrists, cognitive health specialists, mental health specialists that are dealing with the quality of life and everything you mentioned about. So thank you very much for that. And I'm pretty sure that hopefully at the end of the symposium, we'll have a few minutes for the questions, because questions are already coming to my chat. And now it's my greatest pleasure to give the floor to our next speaker, and this is Dr. Bakulin from St. Petersburg. He represents Northwest Medical University of Russia. Good afternoon, dear colleagues. Let me continue non-alcoholic fatty liver disease, and today we will speak about the treatment of non-alcoholic fatty liver disease and the first steps how to do it. So this is how I'm going to make my presentation. But mainly for the first traditionally, I would like to thank organizers of the conference for the introduction and for the opportunity to speak up today. So 3 important key issues. And the first thing is non-alcoholic fatty liver disease, hepatological risks, and the issues of comorbidities. I have to say from the very beginning that this is very short, but very important point, because here we will see the targets for the first steps of treatment non-alcoholic fatty liver disease. So what I want to start with, I want to show you hepatological risks in patients with non-alcoholic fatty liver disease. So here you can appreciate screenshot of European guideline for the patients dated 2021. And this is unprecedented case where European experts wanted to talk to the patients through the guidelines. This is unprecedented. So in the top part of that, you can appreciate mainly epidemiology of non-alcoholic fatty liver disease in general population. So that's about 25%, patients with obesity, which is 80%, and also diabetes type 2. So in this population of patients, we see 2/3, 65% are those who demonstrate non-alcoholic fatty liver disease. So at the bottom here, we see hepatological risks, and please appreciate steatosis, then steatohepatitis, which is NASH, as it is written here, plus fibrosis F1, F2, then severe fibrosis, advanced fibrosis, and then cirrhosis. This is so-called scenario of hepatology. Here you see the other players. This is HCT, steatosis, steatohepatitis, and other players like liver cirrhosis. This is a risk group for HCC development, hepatocellular carcinoma, and we have to keep in mind that. By the way, we all now switch to International Disease Classification version 11, Next week we will have the committee and we will discuss the issues of switch and version 11. So according to the International Disease Classification version 11, we identify two important codes, two types, two versions of non-alcoholic liver disease, which is NAFLD, let me use it, non-alcoholic fatty liver disease without NASH, and NASH as it is, 92.0, 92.1. So there were some hepatological risks described, steatosis and steatohepatitis, and we will come back to that. But here you can appreciate large circle, and these are risks of comorbidities. And among them, we can see first step is a cardiovascular risks and cardiovascular diseases, the diabetes type 2, also renal disease, and more than that, we also see colorectal cancer, even colorectal cancer. So these are all diseases which are associated with non-alcoholic fatty liver disease, and in fact, they can be called comorbidities, and they are all also the targets for the treatment. And we will talk about it later. And definitely we should say a few words about pathogenesis, which is important, which disclose pathogenetical targets. It is very well known that insulin resistance is the origin of non-alcoholic fatty liver disease, and it could be considered as a target. But I would like to tackle another pathogenetic target, which is autophagia of fatty acids, which is very important because this is dissolution of fat inside the cell. And here you see how it all happens. First, drops of the fat goes to the vial, then we use it and then dissolve. So we see the process of autophagia. This process was discovered not long ago by Yoshinori Asumi in 2016, Japanese expert who later on received Nobel Prize in the physiology of medicine. And we come back to this phenomenon later on. And from the point of targets for treatment, potential treatment. And by the way, we can say a few words more here. We can say that autophagia is a critical mechanism of survival of the cell if there is not enough deficiency of nutrients and growth factors under hypoxia, DNA damage, deficiency of nutrients, and also autophagia could be considered as an additional new method, new approach in the treatment for patients with non-alcoholic fatty liver disease. So the second question, what to start with? Here we can start from non-medical treatment of non-alcoholic fatty liver disease. So on the one hand, it's important, but also I would like to emphasize that the treatment of this pathology, it's always a multidisciplinary task. It's always a multidisciplinary task. So here you see two important words, MDT, multidisciplinary team, which is required for the correct treatment of NAFLD. In American Association data for 2020, we see this is the principle of not only supported, but also again refixed again, hepatologists, endocrinologists, nutritiologists, dietologist and also specialist for the treatment of diabetes, pre-diabetes, cardiologists, and other specialists, multiple specialists here. And we have to say that Russian experts also going the same way. So here you see the results of national consensus, interdisciplinary consensus, which was preceding clinical guidelines of Russian Gastroenterological Society that were published in 2022. And we also involved specialists of different specialties. So this is Russian Society for Liver Studies, Russian Association of Endocrinologists, Russian Association of Gerontologists and Geriatrov, Preventive Cardiology. And if possible, I would like to emphasize short information here that allows us, specialists of different specialties, therapists, the gastroenterologists, speak the same language. It all allows us to speak the same language. Non-alcoholic fatty liver disease. Hepatocytes accumulate fat, and figures more than more than 5%. And here again, this is extracts from here. There are two types of NAFLD, more or less benign, steatosis, more or less benign, because with all these features, because there is no inflammation, there is no progression, pathological progression, and there is no hepatological risks. This is independent factor risk for the cardiovascular disease, and second form, no alcoholic steatotic hepatitis, which implements other pathological risks that we already mentioned. So according to the national consensus for the management of patients with NAFLD, and according to the clinical guidelines, there are two main objectives here that we need to reach when we select treatment and options of treatment in patients of these categories. The first task here, this is prevention of hepatological risks, their correction, and reaching regression of steatosis, steatohepatitis, and fibrosis of the liver. And the second one, treatment directed on the prevention and treatment of comorbidities. And this is exactly what we talked about before. So consecutively, the first task here, the first objective could be reached through the modification of lifestyle and diet. So these are not medical tactics, and this is non-medical approach here. That includes modification of the lifestyle and also the diet. And let's appreciate clinical guidelines where you see the level of evidence, where we show here that physical activity, so any aerobic exercises which are performed several times a week for longer period of time, they should be considered as one of the possible approaches, non-medical approaches. And we have to say that our main objective here, the main idea is to reduce fat in the liver. Then dietary recommendations, they say that dietary changes are most effective physiological way how to lose weight. So the key thing here is to lose weight. And also you can appreciate that it is recommended, as it is shown here, it is recommended as one of the options is to select Mediterranean diet, and you see components of the Mediterranean diet. And I'm showing you a screenshot from European guidelines for the patients, dated 2021. So these are products which are recommended, which is included into the Mediterranean diet. And here is something which is not recommended, and mainly we speak about carbohydrates, fructose, and sugar, glucose and fructose containing beverages. The other part here is very clear. I would like to say that patients with NAFLD recommended also hypocaloric diets. It includes diets where the reduction is 500 kilocalories loss or even more from the physiological need. And it could be a weight reduction 5% or more, and we reach regression of the steatosis 7% and 7 to 10% reduction of inflammation. And if you lose weight by 10%, we reach even regression, or we expect regression of fibrosis. It is very clear that the combination of physical activity and hypocaloric diet, minus 500 kilocalories from physiological, could be treatment of choice. And this is level of recommendation B2. And sometimes these are patients without obesity. This is a recommended loss of weight 3 to 5% in order to be in remission of the disease. So these patients also could be very good candidates for weight loss. So it is recommended to have moderate weight loss 3 to 5% in order to reach a remission of the disease. And now pharmacotherapy. And here we considered the issue of what to start with. Well, what should be the beginning of that? We see pharmacotherapy is not simply the continuation of the non-medical interventions, but it could be consecutive and sometimes simultaneous together with the change of the lifestyle. So again, we go back to the hepatological risks. Pharmacotherapy mainly focused on the removal, excess of fat from hepatocytes, which is in the focus. And please remember what we have started with when we started discussing pathogenesis, insulin resistance, autophagy, and pharmacotherapies that could be important that modulate or induce phenomenon or the process of autophagy would be very much appreciated. That would provide a reduction or elimination of lipids from hepatocytes. So it appears to be that ursodeoxycholic acid could be considered as potential treatment in patients with non-alcoholic fatty liver disease. And in the clinical guidelines, we see that ursodeoxycholic acid 10-15 milligram per kilo of weight is considered for the patients with NAFLD as a treatment of choice. So there is induction through 5-adenosine monophosphate activated protein kinase, AMP activated protein kinase, and the level of evidence here is A, so ursodeoxycholic acid. Also, we have to say that ursodeoxycholic acid could be considered as a drug of choice for the reduction of metabolic risks, and it is also very important. At the same time, we already discussed this, the effect to comorbidities, and specifically it has been shown that this is proper level of evidence. Ursodeoxycholic acid provides hypolipidemic effect, reduces the level of total cholesterol, TGs, and also has hypoglycemic effect and participates in the control of glycemia and tracks HbA1c, influences HbA1c and insulin. So the issues of influence of this treatment are quite multiple. So this is pleiotropic mechanism, and one of the possible mechanisms is the influence to 5-reductase, and the other possible mechanism shown here is the effect and keeping in mind that it is an agonist of externiozoid receptor, which participates in the formation of carbohydrates, lipids, and bile acids. So all that clearly explains the situation that ursodeoxycholic acid could be considered as a drug of choice to reduce risks of comorbidities. And as we speak about the prevention of comorbidities, definitely we need to look at other options, other pharmacological agents. In the clinical guidelines, they say that we can use here the inhibitors of gastrointestinal lipases, statins, as inhibitors of 3-methyl-glutaryl coenzyme A reductase, also agonists of GLP-1, liraglutide, semaglutide, and DPP-4 inhibitors that could increase level of incretins, and they are approved for the treatment of type 2 diabetes. We see the improvement of NASH-GVP using these options. So these are the treatments that could be potentially considered, but now we have very good evidence base for the other treatments. Gliflozins, although these gliflozins is a drug of choice mainly for treatment of NAFLD-associated conditions, but in the clinical guidelines for the management of patients with type 2 diabetes, it appeared to be that GLP-1 receptor agonists and gliflozins SGLT2 inhibitors type 2 could improve not only biochemical profile, but also provide a regression of steatosis, regression of steatohepatitis, and even fibrosis. And definitely, dear colleagues, I would like to say that this is something that already discussed. This is something we can start with in patients with non-alcoholic fatty liver disease. And what is at the other end of that? Of course, the journey of the patient is very long, and the journey we go together with the patients with NAFLD, the patient, especially if patient has NASH, it's pretty long way. And this is not multidisciplinary approach which should be implemented. It should be also the approach that includes management of patient, keeping in mind comorbidities and other problems. The main and important part, of course, the approach based on evidence-based data, and definitely we track new pharmaceutical agents which are coming that as soon as they get proper evidence base after the clinical trials, they could come for the treatment of these patients. You see quite prospective molecules about patients with non-alcoholic fatty liver disease that potentially could be very useful, and then it's important for the clinical guidelines. So this is also future opportunities. As conclusions, dear colleagues, once again, we believe that it's reasonable to consider NAFLD as systemic disease that is having particular risks of cirrhosis, risks of comorbidities, HCC risks, non-medical treatment, aerobic physical exercise, hypocalorie diet, Mediterranean diet. All that is focused on the weight reduction and reduction of fat amount in the liver. And we also looked at the use of treatments that could be considered as standards. This is ursodeoxycholic acid, gliflozins, GLP-1 receptor agonists, and statins. Thank you very much for your attention. Thank you very much, dear Igor. So that's very, very interesting presentation. And now it's my greatest pleasure to give the floor to our final speaker for today, our international guest, Ivana Božić-Antić, our distinguished guest from Serbia. Ivana, please share your screen. NAFLD and statins.
Good afternoon. Thank you very much for your kind invitation. I will talk about use of statins in non-alcoholic fatty liver disease. So, as we all heard, non-alcoholic fatty liver disease is the primary cause of chronic liver disease, and it ranges between fatty liver to hepatocellular carcinoma. And it is well established that a great number of metabolic disturbances have impact on this disease, and these are obesity, overweight, diabetes, and hyperlipidemia. And this link between metabolic disturbances and non-alcoholic fatty liver disease implicated in 2020 international panel of experts that proposed a new term, and that is metabolic dysfunction associated fatty liver disease. So according to proposed criteria, every person that has a fatty liver and is overweight or obese or has type 2 diabetes will have metabolic dysfunction associated fatty liver disease. However, the most interesting patients in this group are patients with normal weight. So as we all know, non-alcoholic fatty liver disease is not only a disease of obese people. About 0.5% of those people are lean, and if they have at least 2 metabolic risk abnormalities, which are included in metabolic definition of metabolic syndrome, they will have metabolic dysfunction associated fatty liver disease. So long before this term was known, it was established that patients with non-alcoholic fatty liver disease usually die from cardiovascular diseases and not from hepatocellular carcinoma and cirrhosis. So what is the link between non-alcoholic fatty liver disease, cardiovascular disease, and metabolic syndrome? It seems to be atherogenic dyslipidemia. So how this atherogenic dyslipidemia became the center of the problem? As we all know, there are some genetic influences, some disturbances in fat tissue and in intestines that induced non-alcoholic fatty liver disease. This intrahepatic lipid accumulation induces a great number of fat metabolic disturbances, lipid disturbances, and this induces inflammation, oxidative stress, and adipokine and cytokine production, which leads to not only functional but also structural disturbances in endothelium and cardiovascular system. So the atherogenic dyslipidemia is very well appreciated in new guidelines, and it is a very important thing to think about when we treat our patients with non-alcoholic fatty liver disease. So what is the role of statins? As you can see, and as we heard before, that there are a lot of drugs that we can use in non-alcoholic fatty liver disease. However, statins are probably one of the most important drugs because, as I previously showed you, patients with non-alcoholic fatty liver disease usually die from cardiovascular events. And statins are well-established drugs that can reduce cardiovascular morbidity and mortality. So their action is very well known. They inhibit rate-limiting enzyme in cholesterol synthesis in liver cells. So this induces upregulation of LDL receptors, and there is much more clearance of LDL particles from the blood. Also, they reduce production of VLDL. However, their actions are not only about lipid lowering. They have anti-inflammatory, anti-fibrotic, and antithrombotic mechanisms of action, which are very useful in our patients with non-alcoholic fatty liver disease. So I will show you in a few slides how this works on rodent livers. This study, for example, analyzed atorvastatin alone or together with ezetimibe. And these authors noticed that these both drugs stopped inflammation and improved steatohepatitis and fibrosis in this rodent liver. So it is after that there were a lot of studies that proved that that inflammation is very important and statin use against inflammation is very important. And the probable mechanism is that and explanation is that unesterified cholesterol is toxic for liver cells. So in another study, also on rodents, authors noticed that every statin they used induced gene expression of PPAR alpha, and that is a very important enzyme in fatty acid oxidation. However, in this study, they noticed that this effect was independent of cholesterol level decreasing potency. So flavastatin was most potent in comparison to atorvastatin and rosuvastatin, which are more potent statins. Another studies show that statin can reduce another pro-inflammatory expression of another pro-inflammatory very important genes. And in this right-hand side of the slide, you can see that simvastatin, which is not so potent statin, can reduce fibrosis that already had happened in rodent liver. And to conclude these examples, this study showed that rosuvastatin probably can protect from hepatocellular carcinoma development in the fatty liver. So what about humans? In this study, it was shown on 1,200 patients with a biopsy-proven non-alcoholic fatty liver disease that statin use was associated with significant dose-dependent protection against steatosis and NASH, and also hepatic fibrosis, but only in stages F2 to F4, there was no improvement in advanced fibrosis. However, they also noticed that on statin use, there was a great reduction of fatty activity, NAFLD activity scores, both invasive and non-invasive. This is something that is very interesting for me because we all know that lifestyle modification is the cornerstone of treatment of patients with non-alcoholic fatty liver disease. However, this recent study showed that it was around 600 patients, that only lifestyle change did not reduce these non-alcoholic fatty liver activity scores. These scores are non-invasive, but they didn't reduce them, but all statins reduced these activity scores in patients that were using statins. So statins are very important. In comparison to rodent studies that I showed you, both in humans was detected that statins can induce this enzyme that is very important for oxidative stress and inflammation. So patients that were on atorvastatin, they had much more expressed this enzyme in comparison to non-users. And this very recent study is very interesting because it included around 11,000 of participants with non-alcoholic fatty liver disease. And as you can see here, only 23% were statin users. So although there was a rather low number of patients that were taking statin, there was 43% lower risk of cancer mortality in statin users with fatty liver disease in comparison to non-users. Although we have a lot of data that show us that statin use is good in patients with non-alcoholic fatty liver disease, we have some concerns in our everyday practice. So in next slides, I will show you why statins are safe in this group of patients. First, I would like to emphasize this Greece study that showed us that in patients with cardiovascular disease, and I will say again, cardiovascular disease is a very important thing in non-alcoholic fatty liver disease patients. In patients with cardiovascular disease, patients who were on statin and had initially higher liver enzymes, they had the same liver adverse events as non-users and statin non-users. Another important thing is that patients who had high liver enzymes and were treated with statins, they lowered their liver enzymes during the follow-up in comparison to non-users, in which their liver enzymes went up. And another important thing is that statins reduced cardiovascular events by 68% in patients with elevated liver enzymes. This is rather an old study, but I like this graph very much because this was done on patients with non-alcoholic fatty liver disease, and they were separated on two groups with normal baseline ALT and elevated baseline ALT. So they were treated with the same dosages of a moderate and intense therapy or statin therapy, and they noticed that patients with baseline elevated ALT levels had more reduction of ALT during the follow-up in comparison to patients with fatty liver but normal baseline ALT levels. Also, this study showed that patients who had initially elevated baseline ALT levels had more cardiovascular benefit from statins in comparison to persons with normal baseline ALT. This is a new study done on metabolic dysfunction-associated fatty liver disease. So, as you can see, patients that had high liver enzymes at the start and were treated with statin, they lowered their ALT, AST, and gamma GT. And this lowering was in comparison to lowering of their cholesterol levels. Also, this study showed that the more you reduce cholesterol levels in these patients, there will be more reduction and normalization rate of transaminases and gamma GT. So this is in correlation with a previous study that I showed you that free unesterified cholesterol appears to be toxic for liver cells. So we should lower lipids in our patients. So elevated liver enzymes sometimes happen in patients that start statins. This incidence is low. It can be hepatocellular or cholestatic pattern. Elevation that is above 3-point upper limit of normal is rather low, only in 3% of persons. And we should know that this elevation is usually in first 3 months. And if we have courage to continue statin therapy, this will return to normal in 70% of patients. Usually, this will happen as dose-related problems. So more statin you give, you could expect elevation of liver enzymes. Also, it happens in combination of statin and fibrate. It happens in elderly patients and in patients with chronic kidney disease. Also, we should check what other meds our patients are using in order to eliminate that metabolism of statins and other drugs in the liver. So what is the mechanism of elevation of liver enzyme? Nowadays, there are a lot of studies that show us that elevation of liver enzymes is rather hepatic adaptation. It is something like a mechanical thing. It's not injury. And there are a lot of studies that show that with biopsy proofs that patients who have elevation of liver enzymes during statin therapy, they do not have a liver injury. Another mechanisms are mitochondrial membrane disruption, and it is very important to know that there are a lot of genes that are involved in statin metabolism. So polymorphisms of these genes can make that different patients differently react to statins. Also, we have to remember that there is a small number, but a significant number of patients that can get autoimmune responses and autoimmune hepatitis. So we have to be careful, but we should not restrict these drugs to our patients. So it is very well recognized in new guidelines that patients with non-alcoholic fatty liver disease, high cardiovascular risk, and atherogenic dyslipidemia should be on moderate to high intensity statin therapy. And to conclude, atherogenic dyslipidemia significantly contributes to non-alcoholic fatty liver disease development, progression, and also increased cardiovascular risk. Statins are very beneficial for non-alcoholic fatty liver disease, and they are safe. So if you have a patient with non-alcoholic fatty liver disease, atherogenic dyslipidemia, and this patient does not have greater elevation of AST and ALT, you should start statin therapy. So thank you very much. Greetings from Belgrade and our endocrinology team from Aeromedic. Thank you.
Thank you very much. Fantastic endocrinology team. Fantastic endocrinology team. And also, I would like to thank our interpreters today. It sounded like very delicate and very professional interpretation, and quite artistic, we believe. And thank you very much for that. Well, we have several minutes for Q&A, and we have several short questions to the speakers. If our organizers allow, I will make sort of a wrap up. So Ella, first question is to you. Dr. Pinaeva, question to you. Which diagnostic method is more preferable for NAFLD, non-invasive? What would you offer to the patient with a high BMI, now, for example, 30, and a thickness of the fat fold more than 10 centimeters? Well, thank you very much for the question. Well, I think such patients with morbid obesity, it's a big problem for all methods, for traditional ultrasound and also for the transient and also ultrasound elastometry. We know that transient elastometry, that's thickness of fat tissue 3.5 centimeters, shear wave elastography up to 6 centimeters, it's a bit better. and definitely it could be adequate generation. Well, in such patients, you can try to perform elastography, ultrasound elastography, shear wave elastography, but we need to turn patient to the left side, and then there would be weight of the belly, and then the thickness of the subcutaneous fat would be lower, and then possibly, well, not necessarily, it may work, but still it is possible. You turn patient to the left, on the left side, and then you use shear wave elastography. If you stick to this criteria, well, we can be guided by elastometry. But if you cannot stick to the criteria, if you see it doesn't go, elastometry doesn't work in 100% of the cases, then definitely we need to consider invasive methods of diagnosis, because MRI would also be quite challenging in case of morbid obesity. Thank you very much. Thank you very much. And I have next question here. We all know the specificity of dietary preferences in Europe and in Greece. Sarantis, this is a question to you. What is the prevalence of NAFLD in Greece? You have Mediterranean diet, Greece diet. Do you see it frequently? It should not be the case.
Yes, this is a very interesting question. Actually, we have Mediterranean diet, but we don't have Mediterranean exercise. And the males are very obese in Greece, more than the mid-European rate. So we have about 20-30% of non-alcoholic fatty liver disease in our males, despite our diet.
Well, there is a position that non-alcoholic fatty liver disease is a price we pay for relaxed lifestyle, just like osteochondrosis. It's a price we pay for the vertical walking, for the vertical position. Yes, move, and correct nutrition, Mediterranean diet, plus lots of other interesting directions that we can expect in the future, because probably we will have some new molecules. Ivana, we have some more questions. You haven't started yet, but questions already arrived about the administration of statins. In fact, you already answered in your lecture. Patients with initially increased level transaminases, ALT 97, IST 47. I had such a discussion with manufacturers of metformin. So, because that's one of the key pathogenetic player, insulin resistance, but in the label to metformin, we can read contraindication if there is increased level of transaminases. And I'm always saying, well, please introduce changes, change the label, because we give metformin in order to reduce transaminases. So the same question here, question in Russian, is it safe to administer statins in patients who have initial increased level of transaminases? Please speak up.
Yes, yeah, I would give until 3 times upper limit, but if they're up than 3 times upper limit, I will refer that patient to gastroenterologist first to see if there is some other reason for that elevation, and after that I will think about statins also.
Thank you very much, dear colleagues. Thank you very much. Yes, definitely. Problem of metabolic associated fatty liver disease, MAFLD. It's a big problem for the practical healthcare systems because we need to organize medical care for these patients. And I think we will face many surprises here. For example, one of my PhD students who is working in the multi-profile center, he was dealing with hepatotoxicity of particular drugs. She studied hepatotoxicity in females who were getting systemic treatment with chemotherapies because of breast cancer. And she processed the data, statistical data for the very big pool of females. We identify very interesting phenomenon. First of all, cancer rate, breast cancer rate appeared to be almost twice higher in the group of patients who have non-alcoholic fatty liver disease, that's a surprise, twice higher breast cancer, and chemotoxicity. Toxicity of systemic chemotherapy was much higher in case of non-alcoholic fatty liver disease versus control group. So, and our task, of course, to stick to the protocol, chemotherapeutical protocol for treatment. We need to stick to that regardless adverse events or some biochemical deviations, because we need to get proper results. And I think, of course, this is just part of a challenge, this relation to oncogenesis, cardiovascular risks, fatal risks like acute strokes, MIs. Well, that's very interesting topic. And I'm extremely happy that this topic causes such a big, vivid interest in the medical communities in different countries. And I would like to thank you, because we are absolutely precise on time. This is 4 p.m. Moscow time. That means we have extremely experienced speakers today, highly qualified speakers. And I would like to wish you all the best. Please stay healthy, wealthy, and wise. Success in your work. Take care, colleagues, and stay with us. And once again, thank you very much for the connection. It was very important for our audience to get access to this session, and we're very grateful for your connection and very grateful for your participation. Thank you very much. Have a good day and goodbye.